People coping with mental illness often encounter serious obstacles to accessing the right treatment in a timely fashion. Longtime mental health leader Dr. David Goldbloom knows that problem better than most, and his new book offers solutions. It's called We Can Do Better: Urgent Innovations to Improve Mental Health Access and Care. He is Senior Medical Advisor at CAMH, the Center for Addiction and Mental Health, and a professor of psychiatry at the University of Toronto, and he joins us now from what looks like an incredibly beautiful office somewhere in, where are you anyway, Dr. Goldbloom?
I'm in my bat cave in Midtown Toronto, where I've
Perfect.
been for much of the last year and a bit.
I certainly get that. Now, just before we dive in here, it occurred to me that there are actually four different ways of saying the title of your book. We can do better, we can do better, we can do better, or we can do better. And they all mean, I think, something subtly different. Where do you think the emphasis should be in that title?
I actually think it goes on all four words. And let me explain why I think that's the case. There's a very funny video clip of different actors saying to be or not to be. Uh, Famous actors who've all played Hamlet, and each of them emphasizes a different word and the meaning shifts. But I would put the emphasis on we, because this is indeed about all of us. Can, because it's feasible, and that should inspire hope. Do, because action is involved. And better is because the status quo is unacceptable. So without wishing to dodge your question, Steve, the emphasis is on all four words.
No, I think that makes a lot of sense. Now, I do want to take you back just briefly. About 8 years ago, we did a number of programs down at the Mars Discovery District in downtown Toronto, featuring award-winning innovations that were coming out of the mental health sector. And many of those innovations are in your book. You do talk about them, and the young scientists that we featured then are now leaders in their respective fields. But after 8 years, apparently these treatments are still not really very widespread in their use. And I wonder if you have a theory as to why that is.
Well, there's evidence that the timeline from discovery and innovation to implementation throughout healthcare can be as long as 17 years, which seems unfathomable, except that I would say, number one, old habits die hard. And for all of us as healthcare providers, uh, we learn to do things a certain way, and then we get into our clinical routines, and learning to do things a very different way or think about things a different way is a challenge for all of us. The difference now, I think, is that in the context of the pandemic and the emergence of a vaccine within months, whereas the previous record for vaccine development was, I think, 8 years for mumps. There is an expectation, I think, in the general public that we need to do things faster. And I think one of the benefits, if you're looking for silver linings around the horror of the pandemic, is that the public is going to turn up the heat on expecting better things.
Do you not find it passing strange, though, that there are other countries in the world that are using our techniques more broadly than even we are?
Yeah, it is always a little strange, but my experience of going to other countries is that there are things we're doing in Canada that they're envious of, and we're envious of things going on elsewhere. So, it all comes out in the wash, I guess, but when you're living here and looking at the landscape internationally, you do ask, well, why can't we do that here?
Let's dive in and read an excerpt of the book now as we continue our conversation. And I'll ask Tony Burke, who's helping us out today with the buttons, to put up this excerpt. Currently, you write, there is little logic in who gets what kind of help. It can be more a reflection of where you live, how much money you have, or who you know. Some people end up getting no help at all, while others used highly specialized resources when a simpler intervention could work. In fact, this isn't just an issue for mental health care, it's about how we approach health in general. You point out that we seem to be stuck in a model of mental health care delivery where people may be, for example, treated for a longer period of time than they need to be. Why does that happen?
Well, I think it happens because people get into a groove. Let me be clear, there are some people who do need long-term treatment, and I would include some of my patients in that cluster of people who need long-term treatment, who are dealing with chronic illness, and for whom a brief intervention is not going to make a difference. But there's also the reality that we get comfortable in our relationships with our patients and vice versa. And that may lead to a continuation of treatment when people are already on the flatter part of the curve, that the initial benefits have been a steep rise and then things continue. And when that happens, there are opportunity costs. And the opportunity costs are, given the finite number of providers we have, that there are other people on the outside who are not getting in.
Do you think that most of your colleagues know when shorter term treatment is preferable?
I think so. And I think that there has been a push to recognize our responsibility to meet need. The need is so palpable, and the calling out for help so much more public and loud than it used to be, that I think most people have a real sense of urgency as clinicians about trying to help people as many people as possible, and also looking at what's the shorter term intervention I can do that will make a palpable difference.
We know, even before the pandemic started, of course, that depression was far too pervasive in our society, and it has only gotten worse during the course of the last 14 months. There are many medications to treat it, but finding sort of the right mix for the right people at the right time has always proved problematic for many, many people. Are we
Right.
getting better at that?
I think we're getting better, although we have not eliminated the trial and error that governs our selection, for instance, of an antidepressant. We try to predict based on side effects profile or whether that person has benefited previously from a particular antidepressant or someone else in their family has. But I think one of the newer innovations has been the use of pharmacogenetics, which is looking at people's genetic profiles and trying to figure out from that which antidepressant they might best tolerate or respond to, and thus maybe eliminate some of the steps in the process and some of the cost and some of the delay and some of the suffering.
Understood. Let's pluck another excerpt out of the book, and I'll get you to comment on this as well. Tony, if you would. Clinicians are very good at providing service to the people who come to see them, but less good at thinking about the people who don't come and why they aren't seen. That makes sense, you write. As clinicians, our first priority is understandably the person sitting in front of us in our offices and clinics, not the invisible person who hasn't found the right door to enter. Okay, all well and good, but how does your profession begin to think more effectively about that person who hasn't figured out yet how to get into that door?
Right. And this is what I was referring to earlier in terms of opportunity costs, in terms of people not getting access. And there are a number of ways that we can create more doors. And some of them are physical and some of them are virtual. In terms of physical doors, one of the striking changes over the last several years in Canada has been the emergence of integrated youth services. We're all too familiar with the delays that a number of young people face in accessing mental health care. And, when those delays are measured in months or even years against the denominator of how young someone is, they really become unconscionable delays. The development of integrated youth services that are community based, that are not appointment based, that are walk in, that are places where your initial assessment happens not within months, but within hours, means that you're going to be able to reach a lot of young people who previously might not have been engaged by the traditional system. And we already have evidence emerging from the research being done in Canada that we're reaching some of those youth who might otherwise feel marginalized or excluded. So that's a physical example. But then there's the virtual world. And again, the heat was turned up by COVID. And
Well,
making healthcare available virtually in a meaningful way is part of that solution as well.
let me follow up on this angle of younger people and how they can get in, because, of course, far too many of them end up getting into the system because they're in crisis and they end up going to an emergency department at a hospital. You've got an example in your book where you talk about an organization called SFI, the Strongest Families Institute, which is in Nova Scotia. Maybe you could help us understand how they go about treating kids.
Well, one of the great things about the Strongest Families Institute, which has been around for a while, is that it's a telephone-based service, that it uses counselors who are not from the traditional stock of counselors. They're people often with an undergraduate degree who are carefully coached, trained, and supervised to deliver care to entire families, and they really deliver it from a call center, and they deliver it in the evenings when families are most likely to be together, which is a significant shift from the 9 to 5 weekday world of mental health care delivery that is focused much more on a patient and family centered perspective. And they can make a real difference working with families of young children with attentional problems, behavioral problems, working with the whole family in the evenings and via something as technologically low tech as a telephone.
Hmm. Let me bring you back to the province of Ontario. How well do you think we do here at dealing with this age of clientele?
Well, you'd be better to ask the parents of kids who are struggling, and they will tell you not well enough, not good enough. And we've got some significant family organizations who've been beating the drum appropriately to try to raise more attention, more funding, more resource so that young people get the help they need. So there is uh, fortunately huge room for growth, although that's also unfortunate.
I don't know if there's a turf war going on here, but maybe you can help us understand that. Because, of course, if you need mental health services, there are social workers, there are psychologists, there are family doctors, not just people who are, if I can put it this way, at the top of the food chain, which is where you are. And I wonder whether your profession is at the point where it's prepared to sort of loosen the reins enough to ensure that there is a broader role for more people who can provide more help.
If we look at some of the most successful interventions around improving access to help, it's often been by creating a whole new cadre of mental health providers. The huge experiment in England to improve access to psychological therapies didn't rely on traditional resources, but trained up a whole new group of people in very specific psychotherapy skills and made those resources available to the public. In terms of guild concerns, that somehow we would be losing patients or clients, there is so much work to go around. Nobody is going to go hungry looking for people to help.
Can I just do a follow up on the UK example, because that's interesting? I learned from your book that you don't need you don't need a referral from a general practitioner to get into the system in the UK. You can refer yourself. How does that work? Because I guess it's different from the way we do it here.
It's very different. I mean, our system traditionally in terms of access to publicly funded care. And I want to emphasize that the improving access to psychological therapies in the UK is publicly funded through the National Health Service. In Canada, if you want to go that route, you typically go through your family physician or nurse practitioner who is the quarterback overseeing your health. So this was a big shift to do this the way they did it in the UK, but it has worked out very well. And the people who self-refer are people who are genuinely in need. We have the beginnings of some of that in Canada. Right now in Ontario, Ontarians can self-refer for web-delivered therapist-guided cognitive behavioral therapy, which the province has made available for free to citizens of Ontario.
How effective do you think that is, particularly at a time where many of us are not really allowed out of the house these days?
Well, the beauty of doing it is it's all done through your computer. So if you were looking for an intervention that was tailored to the restrictions of the pandemic, it would in fact be internet delivered cognitive behavioral therapy. And in terms of effectiveness, recent studies in the literature have shown that it is as effective as our traditional face-to-face delivered cognitive behavioral therapy.
Hmm. Let's go a little further down this road here. Mental health apps, how effective can they be?
Well, the apps world is exploding. And one of the beauties of apps is that as opposed to your therapist, they're always available. And when you use them, they're always thinking about you and responding to you. A number of apps have been developed in India, in the United States, and also in Canada to try to improve access to some pretty fundamental psychotherapy. And one of the things that's striking about some of these apps is that they leverage the power of artificial intelligence so that the apps learn about you and also remember things about you that some of us humans might otherwise forget from time to time. So I think that there is huge potential here. The evaluation of apps has lagged behind their development and dissemination, and there's a bit of catch up going on. And understandably, there are also concerns about privacy that need to be addressed with the use of apps, as we belatedly discovered with Facebook and other forms of online interaction.
I bet, though, that when you got into this profession, however many years ago it was, you probably said to yourself at the time, at least thankfully, I'm in one of those professions that will never be replaced by artificial intelligence or machines, because after all, what I do is so utterly personal and unique in each case, you could never be replaced in that way. That may not be true anymore. Is that fair to say?
I don't think that is fair to say. I think what happens is it will redefine what we do at a human level. And, there have been all kinds of innovations throughout healthcare where machines can do things that humans used to have to do. Electrocardiograms that measure your heart rhythm used to be simply a printout that a human had to interpret. Now, the printout comes with an interpretation, but then the human cardiologist reading that interpretation has to apply it to the backdrop of the individual and the physical exam and the clinical reality. So these are tools that allow us to be, I think, a little more refined in what we do as humans. They don't replace us.
All right. In our last few moments here, let's look very specifically at the pandemic. We are learning all sorts of new things about the kinds of mental health treatments that are possible during the course of a pandemic that we might not have discovered had this not happened. I wonder how you think in the long run it will it will affect or change the mental health care system in this province and how it will deal with our needs going forward?
Well, look, one of the big changes for me as a psychiatrist is working virtually for the last 15 months through televideo. And I used to do a lot of televideo to Northern Ontario, but now I'm doing it to downtown Toronto. And it is for patients often a very positive experience, and we have survey data that shows that. But it's also about bringing care to people's homes rather than putting the onus on them to come downtown or to travel or to get childcare or to take time off work. So, in that respect, it can be a lot more patient centered, and the government moved to fund it so that people like me are paid for providing this kind of work. I think post pandemic, this kind of virtual care is here to stay in the menu of options about how people choose to get help.
Well, that's the key question, isn't it? Because in my conversations with people inside OHIP in the past, they've always been leery about giving doctors this right to treat virtually because they were never, you know what? Let's be blunt. They were never really sure about how much fraud would go on in the system and paying doctors for things that never actually happened because there was no example of a patient walking through the front door of a clinic. Um, how sure are you that, in fact, this new option of virtual care is going to stick around post pandemic?
Well, look, I'm not the guy pulling the levers within the government on this, but I think that there is huge public appetite for it that didn't exist previously. And as for fraud, frankly, you still have to write a note on your patient, and people can ask for those notes, and they can interview people and say, "Did you see Dr. Goldbloom on this day?" And they used to do that when it was in person visits as well. Fraudsters will always find a way. But honestly, I don't think my colleagues are fraudsters trying to bilk the system. We're just trying to bring care to people who are constrained by the exigencies of the pandemic.
In which case, let's finish up on this. Is it difficult to remain optimistic about what your profession can do in the face of incredibly trying times that people are living through right now?
No, it's not difficult. And I say that because I have the good fortune of knowing a lot of people in various mental health disciplines and how dedicated they are to providing people with the help they need. And we also get to see the rewards, right? We get to see people get better. And that is hugely motivating and galvanizing.
You know, I want to make sure I say the title of the book the way you said it when I asked you the very first question. So let me try saying, We Can Do Better. Emphasis on each individual word by David Goldbloom. Thanks a lot for coming onto the agenda tonight. So much good information in this book, and we're glad you wrote it.
Thank you so much, Steve.
The Agenda with Steve Paikin is brought to you by the Chartered Professional Accountants of Ontario. CPA Ontario is a regulator, an educator, a thought leader, and an advocate. We protect the public. We advance our profession. We guide our CPAs. We are CPA Ontario. And by viewers like you. Thank you.